Okay, class. So now we'll get into blood pressure assessment technique. When we're assessing blood pressure, we want to use selective listening, right? So we're listening basically to this tapping sound that will be produced after we occlude flow with the pressure cuff. We always want to make sure that when we're placing our earbuds in, so we're going to use a stethoscope here, you want them pointed towards your nose, right? So, if you look down straight at them, right, your earbuds should be pointing anteriorly, right? This is because your, internal acoustic meatus is angled in that fashion. So I'll draw a little diagram here. So here's your head looking down. Here's your nose. There. That's your nose. Here's your ears, right? You want your earbuds pointing in this direction. This is because your acoustic meatus runs in this direction in your head. So if your stethoscope is oriented in the opposite direction, it won't propagate sound as normally. So you want to make sure that your earbuds are pointed towards your nose, towards the front of your face. That we want to make sure the diaphragm, this flat part of the stethoscope, is placed flush and firm against the skin, so we have very good contact along that brachial artery, which is the artery that we're going to be using to hear sound from. And you want it placed 2 to 3 centimeters above the antecubital fossa. And we'll show you kind of what that looks like in the next slide. So again, for placement, we want this about 2 to 3 centimeters above the antecubital fossa. You can usually just use two fingers widths above that crease in the elbow to give yourself enough space. You never, ever want to place the cuff over your scope. That's something you should try to avoid at all costs, because as the cuff is inflating and deflating during the technique of assessing blood pressure, it's going to create sound. It's going to rub against your scope, and it's going to make it actually kind of hard to hear. So you want to make sure that you give yourself enough space to place your scope without the cuff bumping into it. Now, when we're assessing blood pressure using what we call the auscultatory technique, which is using our stethoscope to auscultate to hear sound, you'll hear 5 sounds during this maneuver. So what we're going to do is we're going to inflate the cuff into a point where we completely occlude the artery, and then slowly release the dial to decrease that pressure in the cuff, and it will slowly allow blood to return down the artery. So by doing this, we've occluded flow, so there should be no sound at all that we're hearing. And generally, there's no sound if you place a scope directly over an artery anyway. We have laminar flow in our arteries. Sound is silent. There's not a lot of vibration. However, when we occlude an artery with a cuff, like we're doing here, when we occlude one, there is, again, we've cut off blood flow completely. As we release pressure in that cuff and we allow some blood to eventually enter down into that artery, it returns in a turbulent fashion, and the walls of the artery vibrate, and that vibration produces sound. And that sound can be heard when we auscultate using our stethoscope. So basically all that we've done is we've inflated the cuff until we've occluded flow, and then we slowly decrease and listen for the point or the pressure at which flow is returned, or our arterial flow or blood flow has returned into the artery, which would mark the systolic pressure, which is basically showing that this is the pressure that the systolic pressure wave produced by our heart can overcome to restore blood flow down the limb, right? So if we occlude it to 180 millimeters of mercury, and our heart's only pumping at 100, and our systolic blood pressure is only about 120, we're never going to get flow down, right? So think of it in that terms, right? It's the pressure by which flow is restored, into the limb, or blood flow is returned. As we continue to decrease pressure, that flow, more and more blood returns back into that limb, and then we resume eventually that laminar flow in the artery. And again, laminar flow, there's only small ebbs of the wall, not a lot changes, there isn't a lot of vibration, and when we don't have a lot of vibration, we don't have a lot of sound, and it's silent. So when we hear the return of silence, that marks the diastolic pressure, the resting pressure. When we've resumed laminar flow, which is the type of flow that occurs in the artery during diastole. So the first emergence of sound, again, it's this tapping noise. It's almost kind of in beat with the heart rate, actually, is the systolic pressure. And then the disappearance of sound, or the onset of silence as we continue to deflate, is the diastolic pressure, which is what we call the fifth carotid cuff sound, or identified by the fifth carotid cuff sound. So again, here's our technique, and there's some technique considerations, and this will make more sense when you guys go through the videos that are provided for you guys on technique. But we always want to make sure that the cuff is the right size, and there's some indicators on that to give you whether or not the cuff falls out of range or under range. The bladder should encircle about 80% of the limb, so that's something to bear in mind too. There are different sizes as well. There are small adult, large adult, and then even thigh cuffs for people as well. And you really want to make sure that, again, that the cuff is the right size. If it's too small, it's actually going to cause blood pressure to be artificially elevated. If it's too large, it's going to cause it to be artificially lowered. Either way, it'll be inaccurate. You want it to be the right size. You want to position the patient correctly. The patient should be seated with their back supported, legs uncrossed, feet flat, and the arms should be placed at the level, the right atrium or the heart, which you can observe by basically keeping the heart level with the sternum, or roughly about 90 degrees of shoulder flexion. It doesn't matter which arm that you choose, right? So you can choose either arm. Doesn't matter. Your pressure between arms should be about the same, at most 10 millimeters of mercury different, but they should be identical. We're assessing the arterial system, which is essentially a closed system. And the AHA recommends assessing both arms initially anyway. So you can choose either arm. It doesn't really matter right versus left. Some people say do it on the non-dominant side because there's less likely to be muscle tone, which may affect your pressure reading, but it doesn't really matter which one you choose. You want to inflate the cuff to at least 180 to 200 millimeters of mercury. That's just because we want to make sure that we go to a pressure that is going to be higher than their systolic pressure. If we underinflate, like, we're never going to get occlusion, and then the whole technique falls apart. And we want to release that pressure slowly, about 2 millimeters of mercury per second. And we never want to leave the cuff fully inflated for more than 10 seconds. So you got to get really good at transitioning from full inflation to getting back down to slowly deflating. Because if you leave it on there, it can get very uncomfortable. You're probably not going to harm anybody, but you don't want to leave it on for super long, because they may actually affect the accuracy of your reading, because it causes some discomfort. Now, there is a radial ablation technique, which you'll learn in labs. Basically, it's a way for us to find a very specific pressure, because maybe you inflate a cuff and then you automatically hear a sound. So something to bear in mind when we go through this technique, there should be a period where there is no sound when we've completely occluded the cuff, like the artery with the cuff. Like, there should be a brief period of no sound before we have the first appearance of sound. If as soon as you release the cuff, within a second or so, there is sound, you probably underinflated, because you're really close to that systolic pressure. You probably could have gone a little bit higher if your inflation. And then there's some situations, well, if a patient's pressure is only 100 millimeters of mercury, you don't really need to inflate to 200. That's kind of excessive. So there's a way to use this radial ablation technique where basically you're going to place your cuff on their patient. You're going to palpate the radial artery, and you're going to inflate the cuff until you feel the radial artery pulse disappear. And then there's two approaches to that. So either you can monitor the pressure gauge as you inflate, and then whatever pressure you're at where the pulse disappears, you just add 30 to that measurement for your, when you measure blood pressure, a minute later after that technique. Or you can inflate until you feel pressure or the pulse diminish or disappear in the radial artery pulse. Inflate, maybe 10 millimeters above that, and then slowly deflate, and then wait till you feel it return. So there's a couple different ways to do it. I actually find that second technique's a little bit easier because it's usually easier to track pressure as you're deflating because you have a little bit more control on the needle moving in the gauge. So something to consider. And then basically what you do is wherever the pressure, reemerges or disappears, however you want to go about it, you just add 20 to 30 millimeters above that ablation pressure of the radial artery to use for blood pressure measurement. So that's a way to get a very accurate inflation pressure to ensure that you go above that patient's systolic blood pressure when you're measuring, blood pressure. And again, there's just some errors to avoid here, and this is why it's important because it can cause very, very, very high, or inaccurate measurements to be shown here. Now there is a caveat, like if a patient does not have a clothing that you can expose the arm. You can measure it at the wrist. You can measure, and we'll show you some examples of that probably in your lab. There are wrist cuffs available. You can have a patient wear a gown. If that's not an option, you could measure over clothing. You have to acknowledge that it's not going to be accurate, and it may not reflect their typical blood pressure, but you absolutely have to document that you did. Because again, if you're measuring over clothing, it can elevate blood pressure by about 10 millimeters of mercury, right? So just be mindful of that. That is the absolute worst case scenario, is measuring it over clothing. Now, there are some confounding measurements. Ambulatory measurements and home readings may be more accurate. You'll learn more about that later on. White coat syndrome, some patients can have elevated pressure in the clinic. That's why you see often you go hooked up to an automatic measure and the nurse or medical assistant will leave. There's issues with that. There's also masked hypertension where people get, they have a normal clinic blood pressure but elevated out of clinic blood pressure. There's oscillatory gap, which is kind of related to that abnormal filling pressure or abnormal or incorrect filling pressure. And then there's technique errors and stuff that you can have as well. And we showed you some of those issues in that previous chart. Now, the question I get asked often is about automatic cuffs versus manual cuffs. And I want to put the kibosh to this. So you'll hear people say that, this technique is the gold standard using, a manual measurement. That's actually not true. The gold standard measurement, if we go back to what this actually means, is measuring blood pressure using this, which is a mercury sphygmomanometer. And as we talked about with temperature, no one uses mercury anymore in healthcare because it's incredibly lethal. So this is not the gold standard. These are aneroid cuffs that are using an air pressure gauge, which are accurate, but they are similarly accurate to automatic cuffs. There's no real major difference between the two. And the AHA, the American College of Cardiology, actually recommends both can be used for blood pressure measurement at rest in the clinic. Again, this is your gold standard, and no one's using that except for maybe your office of physical plant in a hospital, which we use for calibrating any of our cuffs, or if you're taking a direct measurement from the artery itself. So either is fine, and there are advantages, right? Both are shown to measure blood pressure accurately. They use different methods. Oscillatory cuffs, again, we talked about that technique for inflating and deflating and listening. The automatic cuffs that you see use an oscillometric technique. So those vibrations that are produced from inflating, and deflating the cuff that we hear when we're auscultating can be detected by a transducer and transition to electrical signals. So that's basically what the automatic cuffs do. They have a transducer embedded in the bladder that detects the vibrations, very small vibrations produced by the return of blood flow into the artery after that period of occlusion. And then they can sense the maximal point of vibration or oscillation, which corresponds to the mean pressure. And then that is used to estimate systolic and diastolic. So they operate from detecting vibration. We, with the manual measurement, are just using that same vibration, but we're listening. It's a different technique, but similar process. Now, in terms of devices, again, there's advantages and disadvantages to either. Manual, you have a lot of more, anytime you include more, a human element, there's going to be a larger opportunity for error, higher susceptibility to white coat response because you have to be physically close to the patient. Advantage of a manual measurement, you can measure during exercise. You can, we teach people how to do this all the time. Automatic cuffs that you'll see in the clinic, like since they detect blood pressure by vibration, they cannot be used during exercise because the vibration we produce from movement causes, it throws off their readings because it's detecting that vibration too. And the advantage though is that a lot less user error, less white coat response, because you can hook it on to the patient and leave the room, and not much of an issue there. And that auscultatory gap, you're less likely to underinflate or be susceptible to very irregular heart rates where you may think you heard the sounds at one point but didn't. So there's advantage to either or. Either is fine to have or to use for resting blood pressure. I would recommend having both in the clinic. And if I'm going to choose one, I'm going to go with having a manual just because I can do more things with this as opposed to this. But either is fine for resting blood pressure. Now, there are some issues with brachial blood pressure in general, right? Like you're only getting a snapshot and it may actually not reflect what's happening at the heart because we're measuring at a peripheral artery. And there are some advantages of measuring this during exercise. Again, this is a static measurement. And when things happen that are bad, like a heart attack or an arrhythmia or some sort of abnormality, like that's going to happen when someone's doing something, when the body is being imposed to some sort of stress. That doesn't happen when you're sitting in a chair. So there is some advantage of measuring during exercise, and in the subsequent courses, you'll learn how to do that. And we're thinking that exercise blood pressure may be more valuable. Another thing to think about is too, there are indications for measuring blood pressure at other locations. Like again, we talked about maybe you don't have, like you can't get their bare skin exposed in their arm. But there are also certain patients where like measuring on one side might be contraindicated. Maybe they've got a lymph node resection or some sort of procedure in their arm. They have a stent placed in or a port placed in, or they have a fracture. You can measure at the wrist, right? Or you can even measure it in the legs in some patients. Like you may have patients that have no arms. You may have patients that have no legs. So you need to be able to measure blood pressure in a multiple different areas to fit the situation in the clinic. So you'll learn more about those in cardiopulmonary and measuring in different areas. It's also a way for us to even screen for certain peripheral vascular diseases. So I'll have you guys practice measuring blood pressure sitting, standing, and supine. Again, follow the techniques provided by the APTA cardiopulmonary section. And then maybe practice using some of those confounders or technique errors, like measure blood pressure in the correct techniques, seated, back supported, legs uncrossed, feet flat, and then measure maybe doing one of those things wrong to see how much it actually throws off your blood pressure measurement. So that was blood pressure measurement, and next we'll get into interpretation.